Hey class, my name is Megan Deese. I am doing my narrated PowerPoint for NU 527 Epidemiology at Jacksonville State University. I've decided to look into influenza and the effect it has on emergency department staff. Emergency department staff, who does it include? Stanford Health states that their emergency department staff and many others involves physicians, advanced practice nurses, clinical nurses, and support staff. Support staff is respiratory therapists, registration, anybody that helps the emergency department function. EMTALA is Emergency Medical Treatment Labor Act. It's a federal law that states anyone coming to an emergency department must be stabilized and treated despite their financial status. This just states that, at the front door, whenever a patient rolls in on an ambulance, they're not asking for insurance cards or co-pays because that's not the important part right now. Stabilizing their emergency is what is important. Emergency department staff are required to treat anyone and everyone that seeks treatment because of this law. Staff is considered frontline care for individuals prior to diagnosis. Staff is exposed to and treats all illnesses. That just means people that come in, we as emergency nurses are treating their symptoms, which means we are being exposed to all sorts of illnesses. By the time they get on the floor, if they're to be admitted, they have been put under airborne precautions or standard precautions, things like that. But right whenever they come in to the emergency department, those things are not initiated, so the emergency staff is exposed. Influenza is a common respiratory tract infection that can lead to morbidity and mortality. It affects 20 to 30 million Americans each year, causing about 200,000 hospitalizations along with 10 to 40,000 deaths. Most deaths obviously related to elderly or those with underlying conditions. The transmission is through respiratory, probably airborne. The reservoir is humans. Animals can carry type A only. Temporal pattern is peak season, December through March in temperate climates, and the communicability is 1 day before to 5 days after the onset in adults. The impact of flu. This is an example. During an outbreak of influenza, 16 of 65 staff members on a unit reported symptoms of respiratory illness. That's 25% of the staff on that unit. Just imagine the unit you work on. If 25% of your nurses were hit, that's a hard hit. Influenza presents a concern for emergency department staff. A trained, qualified healthcare workforce is a necessity in the emergency department. The ER is open 24/7 and requires staff to care for the public. Without adequate staff to implement infection control procedures, the emergency department can become the source of the spread of epidemics. No masks being handed out, no cleaning in between patients, no hand hygiene, things like that. There continues to be other types of emergencies being presented to the emergency department in the midst of the influenza presentation, putting emergency department staff and other patients' families at risk for the flu. That's just saying if you come in with a heart attack or your dad comes in with a heart attack and the whole ER has a bunch of flu positive people, your dad having a heart attack is now being at risk for also getting the flu. This is just a picture here, shows the blood and body fluids exposure by the personnel category, and obviously nurses have the highest at 44%. Levels of prevention, there are 3 levels: primary, secondary, tertiary. In the following slides, we'll talk about how an APN can address each level. But the primary level of prevention is keeping the flu from occurring by removing the cause. Secondary is detects the flu early and provides treatment that can stop it from progressing. And tertiary is clinical activities that prevent deterioration and reduce complications from the flu after diagnosis. I'm going to pretend that's an APN checking a guy out, okay? The role of advanced practice nurse in the primary setting, they can play a huge role in education on the influenza vaccine. Many individuals, what do they say? The flu shot gives me the flu, I'm not getting it. Well, the APN can go back through and tell them that people cannot get influenza from the vaccine. They can encourage individuals to receive the vaccine by answering all their questions and trying to figure out their perceptions of the vaccine. They can make it convenient, bring the vaccine down to the emergency department and administer in the break room to the employees, administer in schools to all the children, clinics, grocery stores, drive-thrus so people have to leave their car, street corners. What about the McDonald's drive-thru? Whoever thought of that? Administer patients in the emergency department? That's a question that would be very beneficial. Patients that come in during the flu season or prior to the flu season when it's time for the vaccine and are being seen for other treatments. Okay, a lot of people are using the emergency department as their primary care office now. So if we started offering the vaccine in the emergency department, do you think that much more people would get vaccinated? We can post statistics on susceptibility on getting the flu shot when not vaccinated and transmission to those who could become in severe state if they contracted the flu. High-risk individuals and healthcare workers are still not vaccinated at the recommended rate. Secondary prevention. In the clinical setting, the APN can perform assessment of characteristic clinical findings to diagnose the flu. They can also obtain oral and nasopharynx swabs within 3 days of onset in order to diagnose. Tertiary prevention, the APN can prescribe treatment regimens such as antivirals, quarantine the individual, rest, drink lots of fluids, treat symptoms such as fever, pain, cough, congestion. Educate individuals in the community and clinical settings to not go to the emergency department when strictly seeking diagnosis of influenza. APNs can design standalone flu clinics to keep those with the flu away from high-risk critical medical patients out of the ER. That's an idea. Could they create these little clinics like an urgent care semi, but that for people to go there strictly when having flu-like symptoms to keep them away from the heart attacks and the strokes and people like that do not need to be in contact with the flu. This is a decision tree. It's used by APNs and physicians when patients present with flu-like symptoms. On the left here we have screen, treat all, treat none, and each side goes out, branches out, whether they have the flu, don't have the flu, they test positive or negative, and if they have possible side effects. So that's just kind of a tree that they can look at and reference whenever they're debating on testing for the flu or just treating. This is a chart here. It just talks about the cost of different things. The cost of a diagnostic test, the flu swab, averages about $20. Okay, then you have all the medication costs of the antivirals, and then you have the probability assumptions. Cost effectiveness, according to the figure on the prior slide that we just looked at, treat empirically is best when the probability of influenza is better than 1 in 3. The test and treat strategy showed cost savings compared with no treatment. Testing before treatment was never the least costly strategy when using antivirals. If antivirals, as you can see, are the most expensive on that chart. So if you're going to test and also use antivirals, that's going to be the most costly. The CDC recommends antivirals as early as possible for those with confirmed or suspected influenza who have severe, complicated, or progressive illness, those who require hospitalization, or who are at greater risk for serious complications. CDC recommends that you go ahead and give those individuals the antivirals as soon as possible. This is a rapid flu test, kind of how you read it, how you perform it. The rapid influenza diagnostic test. Advantages, it produces quick results. Some are under 15 minutes. Some are cleared for bedside use. The disadvantages, false negatives are common, especially when influenza activity is high. And to the contrary, false positives can occur, especially when influenza activity is low. And then they detect influenza B lower than they detect influenza A. However, testing is not required. Repeat, not required to make an influenza diagnosis and prescribe treatment. The cost of the influenza vaccine is $10 to $15 and is considerably lower than the cost of the antivirals. So obviously prevention should be the first line of defense. As you can see there, you have the vaccine, $10 to $15. As you could see earlier on the slides ahead, you have the 4 antivirals, $10, $50, $24, $49, $61, and this is from 2004, so they're just more expensive today. Adverse reactions can occur with the flu vaccine. Local reactions can occur. Guillain-Barré syndrome can occur. Nonspecific systemic symptoms can occur. Influenza screening involves obtaining specimens from the sputum, throat, and nasopharynx. Most applicators are soft swabs. They just are in and out, get the specimen that they need, and then put into the specimen vial. Little to no data can be found discussing the potential unintended consequences caused by screening for influenza. It's very non-invasive, and obviously it's very easy to perform. We'll end here. Get your flu shot, guys. References here, I referenced Stanford Health. I got EMTALA from American College of Emergency Physicians. I used our textbook from the course. Used a study there, cost-benefit analysis study performed. Centers for Disease and Control, obviously the CDC, for multiple sources there. And the Stone, Nurses' Working Conditions, and then Valley Blue Influenza Overview and Recommendations for Control. So, thanks for your time.